I'm a GI medical oncologist at the Dana-Farber, and so my research is really on pancreatic cancer and biliary cancers. Right now, no, unfortunately, unless you catch it very early. But some of the research that we're trying to do is to try to hopefully identify new targets and get a better understanding of exactly what the tumor is doing in patients, so that we can hopefully target it more effectively. I think there's definitely inspiration. My boss, people that we interact with on a semi-regular basis. I mean, even a lot of the trainees, people like not myself specifically, but other postdocs, et cetera. I think the whole environment is really, as you said, there's a lot of smart people. There's a lot you can learn from your colleagues and from your mentors that hopefully will lead to bigger things down the road. I mean, I had some inclination even coming out of undergrad that I was going to go back for graduate school for a Ph.D. Doing research and was interested in biomedical engineering. So had some inclination, but really wanted to get some industry experience before sort of going on for Ph.D. programs. And so while I was in my Ph.D. program, while I was working at Mobile, I really kind of sort of shifted my focus a little more towards medicine. Ended up applying and going to Johns Hopkins for their biomedical engineering PhD program, and then actually enjoyed sort of the medical curriculum enough that I also applied into the combined medical MD PhD program, and so spent a long time at Hopkins doing both degrees, so biomedical engineering plus medicine. The longer you spend in science, I think there's obviously a lot of skill and sort of insight that you develop as you're in the field. But I think there's also a large component of luck, right? Of hitting on the right sort of question at the right time, having the right tools available at this time versus a different period in your research career that allows you to answer a specific question now that you couldn't have answered, let's say, 10 years ago. Even compared to now 20 to 25 years ago, right? The first targeted agents for any kind of cancer therapy were really only discovered in the 90s, late 80s, early 90s. And so since that time, there are now many, many more drugs and approaches that have been sort of developed over the last really 20 years, I would say. And then this whole field of immunotherapy is really, people have been working in this for a long time, but I think the clinical promise is really only now starting to, be appreciated over the last, 5 to maybe 10 years. And so, again, I think there's just this sort of exponential increase in sort of the pace of science. It was important to be able to kind of try to bridge those two worlds, and you're completely correct that they're very different. When you're treating patients, especially as an oncologist, you're really involved in their lives. You see people almost weekly sometimes, and so that's obviously very different than the research side. I think one of the reasons I was particularly attracted to and interested in oncology is because there is this opportunity, because the research is feeding directly into therapeutic development. And really in the span of your career, you can see sort of a drug that was sort of in the very early research stages, gets developed during your career, and then actually goes into clinical trials. That's really exciting, I think, about oncology, and I think very promising. I think that, the way that I've tried to bridge this is really, we do a lot of work with patient-derived samples, not necessarily my own patients, but using tissue from patients, biopsies or surgical specimens, and we're trying to use them in the lab to try to better model patient tumors. And so that's one way that the approach that we've taken, that I've taken in my postdoc to try to bridge those two worlds. I think in the cancer world, it's still, I think, pretty early. I can't say that in pancreatic cancer or even solid tumors, really, there's too much use of the stem cells. More so, I think, to some extent in sort of the hematologic blood cancers. But I think where we'll really see big changes is in the sort of immune immune therapeutic space, right? I think we've just sort of touched the surface, and I think as we learn more and more about how the immune system is interacting with cancers and how we can modulate the immune system more and more effectively, I think that's where there'll be big advances. And I think a whole other sort of area that people are just starting to also appreciate is that immune therapies have their own set of consequences, and so it's really about how do you manage the immune consequences versus the targeted drugs and really get them to work together to most effectively combat patients' cancer. Really for tolerability of the drugs, and in many cases actually even efficacy, they're just much better. Unfortunately, in pancreatic cancer world, still chemotherapy is the mainstay, and there really aren't, in pancreatic cancer at least, many approved targeted agents. And so that's sort of an area that we've been trying to explore. I think one, obviously through the funding, it really helps support my postdoctoral training career. It allows me, I think, to take on some sort of perhaps riskier or more challenging projects that, many research projects sort of take several years to really sort of develop and turn into scientific papers and real insights. And I think having this sort of dedicated funding for a 3-year period is sort of takes off the pressure, at least from, applying for more grants. I guess when you're in science, part of the battle is how do you fund your work, and the other part is how do you actually conduct sort of useful research. And I think by this funding mechanism, it sort of takes off the pressure from one side so you can really focus on the research side. I think the other thing that I've really come to appreciate with Hope Funds is that through these events or other sort of meetings that Leah and others have set up, they really sort of foster a scientific community with other trainees like myself, but also, very senior PIs that, senior mentors that I wouldn't really have met otherwise except through these venues. And I think that is very important for sort of a junior investigator as you move forward with your career. There's some science which is very hypothesis driven. You sort of have a very focused question, and you have sort of the set of experiments that you're going to do are clearly laid out, right? And so I would say that the NIH in general is very good at funding these kinds of projects. But other projects are more exploratory in the sense that you don't exactly know upfront what you're looking for or what the most important finding might be. And so you need some time to sort of essentially explore and figure out, what's important here. And so I think, like, when we started doing our patient-derived tumor modeling, we were, fairly early in the game in terms of taking these kinds of approaches. And, we didn't know how effective these models were, how would they be useful clinically, what can we learn from a basic standpoint. I think it's only now that we're really beginning to appreciate sort of what do these actually represent relative to a patient's tumor, and how can we use them most effectively.